So next I'm going to introduce Dr. Elizabeth Tyler Cabara, and she is our Chief of Pediatric Neurosurgery here at Dell Children's. And she will be talking to us about disorders of head shape and size.
Thank you very much. All right, I'm going to also try to juggle two things at once. I can't do anything simple, so I have to make this interesting. And so the title of this talk is Big Head Todd and the Monsters. This will date me because I will confess that I first saw them in concert before anybody else knew who they were. But I always think this is kind of a humorous way to talk about large heads and funny shaped heads, just to try and keep the mood light. Disclosures, I have no relevant financial disclosures, and we will not be discussing any off-label presentations. So what are the frequent neurosurgery referrals? Big heads, increasing head circumferences, funny shaped heads, small heads, concerns for increased ICP, and perhaps this covers a variety of different problems that may or may not be related to increased ICP. So fussiness or vomiting, developmental delay, and then one that probably is almost always related to increased ICP is sunsetting eyes. And these become sort of the bread and butter of a large part of the referrals that we will see as new referrals in the neurosurgery clinic. So we're thinking a little bit about what are the causes of hydrocephalus. So when these large-headed kids have hydrocephalus, is it aqueductal stenosis or some other structural abnormality? Is it post-hemorrhagic? Is there a history of prematurity and has the child spent time in the NICU? Is it post-traumatic? We certainly see many of these kids. Many of them are identified while they're still in the hospital, but we do see delayed presentations. Post-infectious, the kids who have had group B strep meningitis in the hospital but managed to escape without hydrocephalus still need follow-up because some of those kids will develop delayed hydrocephalus. One we don't see very often but I have taken care of is post-TB. Spina bifida, of course, is a cause, and now with the number of kids who are being closed in utero, where there's a great deal of investment of not having hydrocephalus, we sometimes see these kids actually present quite symptomatic. And of course, we have our genetic presentations. Many of those are diagnosed in utero now. And then last but not least is certainly our patients who are presenting with hydrocephalus because of obstruction from a tumor. All right, so we will keep moving forward with these referrals. And I'm going backwards, so we'll go back to going forward. This is what happens when I try to do things with more than one hand, when I'm not staring under the microscope. So here's an interesting example of a patient who was referred. And so if I can make wow, I bet I can't do this. So you can see the red squares represent what the head circumference looks like it's done, but the blue dots actually show what the age-corrected head looks like, which is slightly, I don't know if that's less scary or more scary. And then here we can see another example of a child who has started way below the curve and has now tracked onto the curve, but in fact has this head CT. And so we have to take not just the trajectory of the head circumference into consideration, we have to take into consideration age correction and also the physical exam. And so in this case, obviously, we have fairly large ventricles. We can see that there is some changes periventricular, and so that becomes concerning for hydrocephalus and requiring treatment. Well, what do we do to treat these children with hydrocephalus? And this is something that hasn't changed a whole lot in many ways. So in the 1950s, we came up with ways to do CSF diversion with ventricular peritoneal shunts or ventricular atrial shunts. And so we have a catheter that gets placed into the ventricles. It runs underneath the skin and then terminates into some space which will absorb fluid. The bladder is a bad place to put it because then you pee out all of that fluid and you end up with electrolyte imbalances. So you want it someplace where you're going to be able to recollect that fluid. The abdomen is our first choice, but we sometimes go to the atrium. We sometimes go to the pleural space. We do crazier things. We sometimes go to the superior sagittal sinus or the gallbladder. We can get very creative if we need to. But there are complications associated with shunting. And so one of the other techniques that has been used is the third ventriculostomy. These are just sort of some of the images of what you would see. So when you're looking into the ventricles, you see the choroid plexus coming down to the foramen of Monro. And when you pass the camera through the foramen of Monro, you can see the mammillary bodies. You can see up here is the infundibulum and the anterior commissure, and then here, where that dot is where we want to come through the floor of the third ventricle, and then you can see these openings through the floor of the ventricle and through the membrane of Lilliquist over this. The idea here is, if you think simplistically, is essentially it's changing the plumbing, but the other part of this is that CSF is almost certainly not a passive system. It is almost certainly gated, and some people believe that the third ventriculostomy actually restores the cardiac gating by transmitting the pulsations of the basilar artery back up into the ventricles in order to help regulate CSF production. The jury is still out because we still don't really understand hydrocephalus well enough to answer that question. We know that in young children, that just doing an ETV typically is not sufficient. It will often scar back over, or it is not. It doesn't really serve the purpose of completely eliminating the hydrocephalus. And so, what has been added to that is choroid plexus coagulation. This turns out to be very successful in post-hemorrhagic, post-infectious and spina bifida patients who were traditionally thought of patients who were not good candidates for third ventriculostomy. But what about the big-headed kid who has benign macrocephaly? This comes in with all sorts of different names, some of which don't sound very benign. Subdural collections of infancy, I don't know. If you say that to the care team, they think that you're talking about a child who's had child abuse. Subdural effusions. Benign extraaxial collections of infancy is a pretty common one. Benign enlargements of the subarachnic spaces. Bessie, the first time someone said Bessie to me, I looked at them like they were crazy. Hypodense extracerebral fluid collections, and the list, as you can see, goes on. So what do these patients look like? Well, they often will have fairly rapid crossing of the percentages in very early. And if you get imaging on these kids, what you see is they in fact have enlarged extraaxial spaces where the density is the same as the CSF within the ventricles. And so the way I explain that to patients is often that the box grew before the brain grew. And so what we will often see with these kids is that, and here's another good example where we've done an MRI, and you can actually see here that this is in fact subarachnoid spaces that are enlarged, because you can see the bridging vessels coming through the subarachnoid space, and in fact the subdural spaces are quite small. These kids will eventually begin to plateau out and track back towards the curve. The other thing is oftentimes there is a fairly strong history of big heads, and one of the things we always look at is how big are mom and dad's heads, because what you will see, particularly in this example, is dad's head was way above the 95th percentile, and mom's head was really sitting right at about the 95th percentile. So we can easily say to the pediatrician, we anticipate that these kids are going to hang out above the 95th percentile, and that is an acceptable place for them. All right. And so here we've begin again example of them tracking back. So when we are looking at a kid with a big head in the clinic, we are looking at how rapidly or how many percentage lines have they crossed, and are they disproportionate to their parents? If they're truly disproportionate, that is when we will consider obtaining imaging, or if that rise has been really out of proportion to what we would expect with the benign macrocephaly. If it's normal, then we're pretty much done, unless there's concerns for increased ICP, in which case we'll continue to follow. If the imaging is abnormal, then those patients get referred to neurosurgery. There you go. All right. So with the treatment of the benign macrocephaly, really we do not do much in the way of significant treatment other than watching. If we become really concerned, we can do an LP or ICP monitoring to determine whether or not they have increased pressure. And if they do, then we can move towards ICP, some kind of diversion. This is in the difference here would be the non-accidental traumas, and in these cases you can see that now instead of, we clearly have both the subarachnoid fluid spaces and the subdural fluid spaces, and the majority of these patients will go on to need to be treated. I think one way of trying to sort of differentiate these two when you're seeing these patients is the benign macrocephaly is often going to have a soft fontanelle. They're not going to have distended scalp veins. Their sutures are going to be normal. Whereas in the hydrocephalus kids, you're often going to see a tense or fuller bulging fontanelle, the distended scalp veins, and displayed sutures. So the other common referrals to neurosurgery are our patients who come in with funny shaped heads. And this is just a brief slide to show you and remind you about the sutures that are in place that help the skull accommodate that rapid growth in the first 2 years of life. Probably the most common one we see is metopic synostosis, and so these kids have a early fusion of the metopic suture, or down the middle of the forehead, and you can see that what they can get is this very triangular shaped head. Many of these kids don't need treatment, but the ones that have profoundly trigonocephalic heads, like this one here, with real pinching across the temporal lobe, temporal region, may in fact benefit from treatment and referral to the craniofacial clinic. Sagittal synostosis comes as a single suture fusion, and that is the middle suture, and that in order to accommodate that, you get growth of the head front and back, producing the dolichocephalic, or the long skinny head. These kids now are typically referred for surgery. One of the ones that we see, actually have seen quite a bit of recently, is the coronal synostosis. So when you have a single coronal suture that is fused, you end up with the raised eye. It is usually quite noticeable, and usually the parents notice this really right at birth. If in fact you end up with both of those sutures fused, you will just get a very short, high head. Once we start talking about more than one suture fused, we do start worrying about increased ICP and some urgency to treating those children. Lambdoidal synostosis is probably right now one of the ones that is most difficult for people to identify because it can look a lot like plagiocephaly. But in the lambdoidal synostosis, the contralateral ear comes forward as opposed to the ipsilateral ear. And it is contralateral frontal bossing, which is similar to what you see with plagiocephaly. So it's really looking at what happens to the ears. These look more like a rhomboid, whereas the positional plagiocephaly look more like a parallelogram where everything is just shifted together. We also see a fair number of syndromic cases. Oftentimes there are family members who have had this. These are genetic and have typically multi-sutural abnormalities, and often have other abnormalities associated with them, whether they are with the hands or developmental delay, and some of them are also associated with hydrocephalus. So as I mentioned, a lot of the metopic synostosis can be actually just observed. For many of these, if we can identify children in the first 3 months of life, they are a candidate for springs as opposed to extensive surgery. The springs, this is a great example of what this looks like. Some people leave the strip, some people don't. We get rapid expansion from those. When we have to do a larger surgery, as you can see here, it often includes removing a chunk of the skull, then doing remodeling of the skull in order to try and achieve space so that we don't have problems with increased ICP, and to achieve a better cosmetic effect. Positional plagiocephaly has become epidemic as a result of the Back to Sleep program. It is also often associated with torticollis because kids will tend to lay on one side of their head. Most of these kids will improve simply with repositioning and tummy time, but some of them will need a different interventions. This is characterized that the lambdoid suture is in fact open and the ipsilateral ear comes forward. So you really see, like I said, that parallelogram shape. So besides the tummy time and PT for torticollis, we recommend lots of repositioning. If it is inadequate, we can recommend a helmet. Typically, in order to have that approval, we need to have frontal bossing and ear abnormalities. And these are the some of the typical types of helmets that are available that do require that it may not be covered by insurance, and it requires 23-hour-a-day wearing and frequent visits. Again, some of the differentiations between these two are normal ICP versus increased ICP, and the likelihood that it can be treated with just conservative measures versus requiring some sort of surgical correction. Thank you, and I think I have a few minutes to take some questions. Yes, Dr. Deputy.
Okay. So there is a natural history of improvement of head shape with positional plagiocephaly. As the brain grows, it pushes on the skull bones. What is the evidence, or is there evidence that the skull molding helmets will improve the shape of the head over the natural history?
So that's a great question. So in Canada, it is actually nationally no longer recommended to do molding helmets, and I think that's actually now made it into the pediatric literature in Canada. It actually turns out that there have been done some controlled studies that have been done looking at kids who have had molding helmets and those who haven't at age 10, and looking at their cephalic indices, and in fact, there's very little difference. And so there are definitely some people who really are proponents of not using molding helmets. The use of them in mild plagiocephaly, I think almost everybody is in agreement that that doesn't make sense anymore. In the kids who have significant facial asymmetry, although that will likely balance out for the most part over time, because of some of the social concerns, that has been one of the reasons why people have still advocated using the molding helmets to try to improve that facial symmetry for social reasons. But I frequently will counsel families that, you know, as long as we continue to do these things, we will continue to see improvement 6 months out, 9 months out, 15 months out. And so there is definitely some disparity, and you will find the practices for molding helmets differ vastly depending on where you are and how aggressively the companies that provide molding helmets advertise. You had a question in the back.
Yes, so for mild to moderate plagiocephaly, where the family's having trouble doing the tummy time and repositioning, and it's just really taking the child a while to get better. Have you had any experience with those tortles that you can get over the internet? It's like the little caps that have like a, where, especially when it's like more on one side than the other.
So I'm gonna be really, so one, the turtles, I think that's really marketing. I don't know that we've seen anything. So I am, I'm a mom who had a kid with a full head of hair, and I'm the only one besides the plastic surgeon, who is a good friend of mine, who knew she had plagiocephaly. And once we figured that out, I'm a living proof of what you can do with repositioning if you're crazy. My child was never allowed in a car seat unless she was actually in the car. She was never allowed in a bouncy seat for more than about 15 minutes, because otherwise she would nestle back onto that flat spot. So my kid got carried around in a baby Bjorn, like nonstop, and it worked. I mean, it definitely worked. So when I talk to families about this, I at least am able to say, no, it's not just switching arms when you feed, it's get them off that flat spot. But where we really do run into challenges is developmentally delayed children, kids with significant torticollis, and we've actually seen some issues where kids who have had shunts, and now they've got these funny shaped heads because their hydrocephalus has collapsed. We've actually found molding helmets work really well in some of those patients, although people are usually a little woodgy about doing it. All right.